Okay, so I'm Dr. Joan Neehall. I'd like to welcome you to this edition of our fantastic podcast. It's entitled Eating Disorders, or as I like to say, what's eating at you. So today we have a renowned guest. We have Dr. Julie T. Anné Zeig in our audience. She's an expert on complex trauma and how the trauma affects our eating. And I think that's fantastic. She's a licensed psychologist. She's the founder of New Beginnings. I'm going to have to look at these notes, guys, because she has so many things to her name. She's an international presenter. She's a consultant. She works at the Mayo Clinic, guys. She's a guest lecturer and consultant, don't you forget. In addition to this, if you haven't heard enough, she's our on-air psychologist. Just think about it. So, Julie, I'm so thrilled that you finally had time to join us.
I am so honored to be here for you, my dear friend and my esteemed colleague.
So, thank you. You flatter me, but I'm glad I fooled you so well. But, so the thing is, there's so much we can talk about. I wish we had 25 hours, because the first thing that comes up for me is, I don't know if you've seen it this way, but what I've noticed with my patient or client load is that a lot of people are experiencing, because of all of these tragedies, if you will, or common tragedies in life, they're experiencing a loss of control, loss of identity, loss of self-worth, and all of that. I think I'd like to turn the lens on you, because I think it goes right into your area of expertise. How is that affecting eating disorders and trauma?
Sure. Well, we certainly know that COVID has not been kind to mental health in general, and that's especially true with eating disorders. We know that especially for adolescents in 2022, eating disorders increased, believe it or not, by 104%. So you're right. I think situations like social isolation, lack of control, uncertainty, lack of predictability certainly, I think, exacerbates underlying dynamics that then increase eating disordered behavior. So we always know that there are going to be social aspects that fan eating disorders, but I think it's also important to know that there are internal dynamics at the core, at the foundation of self, that really are important to pay attention to when we talk about eating disorders. And in my opinion, we don't talk about that enough. And that's part of my platform in bringing forward this discussion on complex trauma-driven disordered eating.
Can you talk to us a little bit more about that?
Yeah. Well, I think when we talk about eating disorders, it's very easy to think about, well, eating disorders are really about an unhealthy relationship with food. And I can't argue that. That is true. But that really is more on the behavioral level of things. I like to start out a discussion and say eating disorders are really about an unhealthy relationship with self, and really are about your psyche's brilliant way of stepping in and utilizing maybe a maladaptive relationship with food and maybe a maladaptive control or manipulation of your body, but it utilizes that in a means to try to help you to psychologically survive. And that's what eating disorders are really all about, an unhealthy relationship with self.
And you link that to past trauma, Julie?
So oftentimes,
complex trauma, our audience needs to understand that, and I think
Sure. So let's talk about complex trauma. First of all, that's such a buzzword, and I'm grateful for that, because it's important that we start recognizing what that is. But few people truly understand it. So just to be very brief, complex trauma is going to be experiences, actually multiple experiences of interrelated and multiple forms of trauma, abuse, neglect that happen early in childhood during our most formative years. So we're talking about physical abuse, we're talking about emotional abuse and neglect, and we're certainly talking about physical abuse that happened early in life. And because it happens early in life, it happens, unfortunately, at the hands of our early attachment figures and experiences. And actually, that is part of the definition, that this is trauma at the hands of our primary attachment figures. Okay, so this is during the most tender time of our unfolding self, when we are learning about our world, we're learning about the safety of others, we're learning about our sense of control or lack of, we're learning about our self-worth and our self-value. And when this trauma occurs most of the time in our home, it happens in a chronic manner. And our psyche has to find some way to adapt to this ongoing abuse. And so disordered eating is one of the ways that we eventually adapt to try to cope. Now, that's a lot.
Brilliant. I think that's really good, Julie. I like what you said, because you see, I think I look at polarities at times, or dichotomies, and I see what you're talking about: attachment on the one hand and authenticity on the other. And I guess that's where you come in as the therapist and the expert, and you teach us how to be authentic and also deal with the attachment component of it. Huh?
Well, it has to be safe to be authentic. Right?
Of course.
So for us to allow our real self to be seen, we have to feel like it's going to be safe and that people are going to respond to us in at least a neutral and hopefully a positive way. We need to make sure that when we express our emotions, that is going to be safe. And oftentimes with these early beginnings, it is not. So again, we work to adapt on an unconscious level. We disconnect from our emotions. We disconnect actually from our experience of ourself, which includes our body self. And we are guarded towards others because we don't want to get wounded over and over again. And so these are the underpinnings of unresolved complex trauma. And when this remains and we become an adult, we have to find some way to manage in the world, to self-regulate, right, to cope on a daily basis. And our unconscious default mechanism for us all is going to self-soothe by unconsciously using food. Okay? Think about it. At the very beginning of life, we all have had the experience of coming into this world, experiencing stress and trauma at kind of the birth, and now we're in a world that's unfamiliar. It's uncomfortable. We might be hungry. We have physical dysregulation. We cry, and then we are hopefully responded to with warm, oftentimes beautifully hormone-laden milk that calms and soothes us, right? Our system calms down. And so from the very beginning, our neurological system gets wired with discomfort and dysregulation, food, calm, right, satisfaction, right? And so when we are not able to respond to ourselves in a healthy way because of unresolved complex trauma, oftentimes that default setting is to go back and to utilize food in a completely unconscious and sometimes compulsive manner.
Yes, you're talking about emotional dysregulation that occurs, different forms of abuse that would lead to this pattern of behavior.
Yeah.
No, that brings up something for me right away. The question is, it feels like the analogy for me is the myth of Sisyphus. You roll that rock up, lost the weight, and then it goes back down, and you're right where you started with a couple of extra pounds to do to carry on with that rock. How do you deal with that, Julie?
Well, you're talking about a couple of different things. So the first thing I'll say is from a complex trauma conceptual lens, which I apologize, but that's always my lens. Often,
Don't apologize. That's
oftentimes, let's say if, let's say in anorexia, and this will be kind of the reverse of what you've talked about. Well, you know what? Let's use your analogy. Let's use somebody that is overweight.
yeah, and they're trying to lose weight.
And let's say there is, which is oftentimes the case, a history of unresolved, let's say, sexual trauma. If somebody loses weight and they feel exposed or vulnerable, they start getting attention. They start having kind of this risk of sexual or emotional intimacy, and they're ill-equipped to deal with it. They've never become really yet skilled on how to manage boundaries, to say no, to kind of own their body self, right? So unconsciously, they are going to get very anxious, and they will then turn to food and regain the weight. We know that this happens. In fact, the ACEs, the Adverse Childhood Experiences data was actually collected on a population of individuals that were in a weight loss program. And the wonderful researchers started looking deeper into the causes of why people who were actually successful at losing weight were dropping out of the program. And he started asking questions, deeper questions, and he found in like 99% of those individuals a history of unresolved sexual trauma. So I say, why are we not looking at this more readily when we are treating eating disorders and issues of weight? So that's my complex trauma lens in response to your question. But then I'm going to give another answer. And that is that if someone loses weight through dieting behavior, okay, we know that dieting behavior, any diet that you lose weight, 95% of the people will regain all of the weight that has been lost within 1 to 2 years. 95% of the people who lose weight through dieting. So dieting is a completely long-term, ineffective means of weight management and weight loss. It's ineffective. Does that surprise you?
No. I believe in the anti-diet system, never mind. And like you, I run, so that's okay. So the point I guess I'm getting at is, from your perspective, what are some of the solutions? What I'm hearing is we need to buckle down and deal with the trauma, the complex trauma from childhood. And if we've been numbed by it, or we're scared to even look at it, or even perhaps suffering from retrograde amnesia, I think what you're saying is that if they come to a person like you and feel safe, all that therapeutic alliance is what you're talking about, and feel respected and honored, and know that they won't be abused.
Yeah.
By being judged. Yeah.
I love your heart, and it touches my heart, and it, It literally brings tears to my eyes. I travel all over the world and at Mayo, and I urge every clinician, whether you are a therapist or a psychiatrist or a medical doctor, to please approach every single client with the possibility that you are sitting across from a trauma survivor. We need to recognize that everybody should be treated with respect. Everybody should be treated in an empowered way where they are encouraged to have a voice and to collaborate. You are not the expert. You are there to support them in their treatment, but they are the expert over their self and their experience, and certainly their body. And we need to create that respectful, safe, compassionate approach. And when we do, our clients are going to be more forthright. they're going to feel comfortable to tell us what many times they have not told anybody ever in their life. I can't tell you how many times I work with people well into their 50s that disclose trauma and abuse. And they say, Dr. Julie, I have never shared this with anybody. Never. So we are privileged as providers, and we have to recognize the vulnerability and the gift that every client is giving us by stepping into our office and trusting us with themselves.
It's such a courageous act that they have that ability to do that and to spend their hard-earned money and sit here, and I, like you, Julie, I guess I am always when I work with a patient or a client, I'm humbled.
Yes.
By their courage. And I don't know about you, but for me, I have found the times the comfort of just holding them with my eyes, letting them have comfortable pauses. And that pause might extend from one session to another. I need to go march to their rhythm.
Yep. It's called loving attunement. Loving, healthy, appropriate, respectful attunement. And this is why you and I connect so readily, because our hearts as human beings are the same. And I think our hearts as clinicians are the same. And, I'm always surprised as I go out across the world, and I'm met with people that thank me for giving them permission to be clinicians that step into that interpersonal space with their clients. Yes. Now, I'm going to say that again. They thank me for giving them permission to be one human being sitting across from another in a sacred space. And I think that the advent of, I will say this, managed care, in the 90s, treatment models that poo-poo the strength of that interpersonal connection. And in a lot of times, poo-poo people's histories, right? Like they make it a negative taboo to go and do a deep dive into somebody's developmental and family of origin history, what I call a complex trauma assessment, which I do with every single client that walks into my office. We have to recognize that we need to open up that space to really understand what's created the behavioral and emotional dysfunction that we're seeing in our office. We have to put together a 2,000-piece puzzle to really understand what we're treating. And when we do, our treatment will be so much more effective, and it will take less time. And guess what? People will change for good. They will change in a lasting way because they've changed from the inside out. And that's really what my work is all about. People deserve that. That's what every client deserves.
So with the advent of AI and our propensity as human beings to want a quick fix, what you've just explained is something that warms my heart. You can have a quick fix if you're prepared to do the work and dive deep and take that act of courage. And then you're saying recidivism won't exist because you've gone within. Paradoxically, you have to go in. It sounds almost counterintuitive when you consider healthcare is telling us, well, you'll get paid for 6 sessions and that's it. So please get the cookie cutter out and deal with it. Boom, boom, boom.
Exactly. And what ends up happening, Joan, is that our clients are the ones that then blame themselves. They say, what's wrong with me that this behavioral change didn't last? Right? What's wrong with me that I can't simply do what I'm, cognitively aware that I should do, but I can't do it. Right?
That in turn increases the trauma, increases the cycle of violence and abuse.
Yeah.
It does. Because you start taking the shame, you internalize it, and the guilt, and it's mea culpa, mea maxima culpa, instead of stop.
Yeah. You're spot on. Absolutely. Because somebody coming from that place is not going to look and say, hey, these treatment models are not effective enough. They're going to say, what's wrong with me? Because they are going to come from that core of shame, that lack of self-worth. They're demoralized. And unfortunately, our field, both medical and psychological, can be inadvertently shaming. What's wrong with you? I see that you've put on more weight since last time we evaluated you. You've regressed once again back into your eating disorder behavior. And it's shaming and it's demoralizing. And the responsibility is really on the clinician, right? We're the ones that need to be skilled and be aware of how our clients are going to hear our messages. So we have to be very deliberate. How do we give those messages? How do we talk, if we're a physician, how do we talk about weight status instead of, the number on the scale in a shaming way, right? How can we explore your relationship with food to see if this is binge eating disorder or if this is just simply a lack of knowledge regarding healthy or appropriate nutrition? There's so many areas that we need to improve on in this very tender and complicated area of relationship with food, body, weight, and self.
Because it can lead to post-traumatic stress disorder. If you go to a physician, for example, and you're accused of, oh, you overate again, or oh, you didn't lose weight. What did you do wrong? Or if you go on the scale and Weight Watchers, God forbid, I'm not blaming any diet, please, that listeners. I'm just saying that these things set you up to fail. And I like looking at it differently. And I say to people, I don't go on the scale because it is the truth. I believe that if you go on the scale, fat weighs less than muscle. So if you're gaining weight because you're running or you're weight training, excuse me, do you see the point?
Oh, absolutely. And, what I will say is, I think that therapists and medical physicians are so overburdened with everything that we need to know when we treat clients and patients. And I will tell you, in medical school, most medical schools give no training whatsoever on eating disorders. So physicians are not even introduced to any of these concepts. So I think that, I just urge providers to be as educated as they can be. I think their hearts are very likely in the right place. But if they are uneducated and unaware of what they are inadvertently doing, the client is the one that is going to suffer. And unfortunately, they're going to go away and they're not going to come back. And they're going to suffer within themselves. And we are the ones who have failed them.
See, that's why the first session is so crucial to establish that alliance. And I say to new therapists, pretend this is the last time you're going to see this client.
I love it.
And if this is the last time you're going to see this client, are you just going to tell me what your problem is and blah, blah, blah? Or are you going to figure out where I need to go from here to there? And in your case, can we deal with some of that pain now?
I love it. I think that that's a great thing to offer new clients and for seasoned clinicians to remember that as well. Over and over and over again, and I cite this in my trainings for professionals, we know that since the 1950s, the trait that predicts a positive therapeutic outcome is not which therapeutic technique or which school of thought. It is a positive, safe, and supportive therapeutic relationship. Okay. And the second most important trait, guess what, is a positive therapeutic outcome, or the expectancy for a positive therapeutic outcome in the form of hope. Hope. And that's what we as clinicians need to, number one, feel in our hearts, And number two, offer to our clients that are trying yet again to finally be able to live the life that they want to live, to finally feel about themselves and their body the way they long to, and are risking once again to be in front of us emotionally and sometimes with a physician physically naked, asking for help. So hope in a positive and a safe therapeutic relationship is the most important factors.
So it brings to mind what one of my favorite people, Viktor Frankl, says.
And
right?
mine.
Without, hope, there is no meaning. Without meaning, there is no hope. And I tell people that meaning is one of the cornerstones of happiness. To be happy, you have to have a meaningful life. You have to know that this is where you're going. So even if you're going to tell me, like a client said to me recently, well, Joan, I think I'm experiencing guarded optimism. I said, that's great. I'll take that. Any tips you want to give us, Julie, before we end today?
Oh, my goodness. Let's see. I would say for professionals, what I would say is please know that eating disorders, anorexia, bulimia, binge eating disorder, emotional eating, chronic struggles with weight are 100% treatable. Believe it or not, I have really fought that myth that was in existence 30 years ago, that once you had an eating disorder, you were destined to struggle for the rest of your life. So please know that eating disorders absolutely are treatable. Please look at your clients through an additional complex trauma lens. Do appropriate and comprehensive assessment, and then connect the dots for your clients. It will help them reduce shame, and it also gives them more hope when they say, oh my gosh, I didn't know that this was connected to this, and this is why I did this. They feel optimism because they have something to work on, and that provides them with hope. I would say if you are someone that's struggling yourself, I would say know that there's good therapists and clinicians out there. Find them. And then what is ultimately the most influential reparative relationship is the relationship you form with yourself, ultimately. And that's a long journey, right? We don't want to just say, love yourself, say positive affirmations. That can be superficial, but getting to the point where you have a reparative, healthy, attuned, loving, supportive relationship with your entire self, your emotions, your body, your attunement to yourself, is going to be what helps you to fully recover and to live in a manner that you feel good about yourself from the inside out for your entire life, regardless of your weight status. Regardless of your weight status. I promise.
Love what you just said, because it is true. And I think that clinicians need to be aware that we human beings are multifaceted. So when a client presents with an eating disorder, don't just pull out your file folder and say, okay, this is what it is, and I'll go through the check spots, and here is the formula. I think sometimes physicians in particular need to be aware that the client is presenting, or your patient, with many faces. And one of the layers in the layer cake could be depression. Another one could be anxiety, generalized anxiety, whatever's in there. For heaven's sakes, be aware that it is complex, not just complex trauma, but the person is complex.
Absolutely. And take the time to tease apart all of those pieces. The time that you take to really recognize what you're dealing with and how everything connects together will serve you very well. It will actually make the treatment shorter, and it will make the recovery process completely effective forever. That's how we get people to be 100% healed, and we need to do that better. I really am a stickler with that. Everybody deserves to live a life that is happy and fulfilled, regardless of your beginnings. And oftentimes, especially because of beginnings that were hard. Everybody deserves that. That is at the core of my soul. And I know it will be for my entire life. That's my work. That's my purpose. That's my meaning.
And what Judy is saying, I want to thank you for saying it to our audience today, is that it's important to know that not because you've been labeled bulimia, anorexia, binge eating, obsessive compulsive disorder, whatever, be aware that help is there with seasoned therapists, licensed psychologists like Dr. Anné, who is willing to take you on that journey, that painful but safe journey, just like drinking your mother's milk, suckling at the breast.
Absolutely. I love it. Thank you so much, Joan, for your heart, your incredible insight and clinical acumen, and mostly your friendship. You are a blessing in my life.
You too. I must tell you this. I am honored to know you. And I think you're an amazing, amazing gift, not just in my life with myself and my husband and Jeffrey, my friend, your husband, but people in general. You know, audience, if ever you get the chance to see Dr. Anné Zeig, you'll notice what happens when you watch her enter a room. People jump, they smile, their eyes light up like a Christmas tree or Hanukkah series of candles. And on that happy note, I'll say bye, guys.
Thank you so much.
Thank you for joining this discussion on happiness. We hope this helps to inspire you to lead a more joyful life. To dive deeper into the subject of happiness, be sure to check out Dr. Neehall's book, Happy is the New Healthy, available as an ebook or hardcover. For additional resources, visit our website at drneehall.com. Until next time, stay happy.